This is Lauren Dunlap for Advocacy and Awareness for Immune Disorders Association, or AAIDA, in Charlotte, North Carolina, and I'm happy to host this afternoon's educational webinar. AAIDA's mission is to provide support and advocate for the greater than 25 million Americans living with immune disorders. AAIDA works to promote research and create better awareness of immune dysregulation conditions. Today, I'll be joined by immediate past president of the American Academy of Dermatology, Dr. Mark Kaufmann. Mark Kaufmann is a clinical professor in the Department of Dermatology at the Icahn School of Medicine at Mount Sinai in New York City, and immediate past president of the American Academy of Dermatology. Prior to joining Icahn School of Medicine in 1995, Dr. Kaufmann was in solo private practice for 23 years until he joined the Dermatology Group in November 2017. In September 2020, he joined Advanced Dermatology and Cosmetic Surgery as their chief medical officer. Dr. Kaufmann has served on the American Academy of Dermatology Board of Directors, as well as serving as chair for the American Academy of Dermatology committees. In addition, Dr. Kaufmann currently serves on the board of directors of the American Society for Dermatological Surgery, the Florida Academy of Dermatology, and an advisor for the American Academy of Dermatology team and Relative Value Scale Update Committee, a position he has held for over a decade. Dr. Kaufmann received his medical degree from New York University School of Medicine, completing residency training in dermatology at the Albert Einstein College of Medicine in the Bronx, New York City, and is board certified in dermatology. Dr. Kaufmann's contributions to the American Academy of Dermatology have been recognized by his receiving a presidential citation in 2013, 14, 15, 17, 2020, and 2022. With many articles published on the topic of health information technology, Dr. Kaufmann is a frequent national lecturer, including the American Academy of Dermatology annual meeting, other national and regional societies, and grand rounds. Dr. Kaufmann, thank you so much for joining us this afternoon. Excited that you're here.
Thank you, Lauren, and thank you for that kind introduction. I just want to start by talking about how I got interested in this topic. Fairness has always been essential and central to the way that I view the world, and our specialty is not often treated fairly by some of the other House of Medicine groups, and so that caused me to advocate for dermatology. But one of the things that was really bothering me was the cost of medications, because it's not only bothering me, obviously, it's bothering everyone who's on this call, listening to this, watching this. And it became apparent to me that what our preconceived notions are not necessarily what's going on. And so I dug into it, and today I'd like to share with you what it is that I see as the problem. I have no financial conflicts with this talk. So we've all seen the headlines. We all know that drug prices are very high. The amount of people who can't afford their drugs keeps going up every year. And basically, there was a survey that went out by the Kaiser Family Foundation, found a lot of things that were very unusual. And we also are dealing in a country where the per capita cost of medications is over $1,200 per capita, and that is way more than any other country in the modern world. And the Kaiser Family Foundation survey had one question that I wanted to share, because most people who answered the survey got the answer wrong, and that is, who does the public trust to lower prescription drug costs? And it depends who you ask, right? If you ask Democrats, they thought that the Democrats would be most likely to decrease the cost of medications. Republicans thought Republicans would, and independents thought that neither would do a great job. And actually, the independents are closest to the correct answer here. And you will see by the end of this talk where that box of 17% of neither, there's a reason for that. And after this talk, that box probably would be close to 100. So what is the problem? Well, the problem is that this animated graphic that I'm showing you here is about the 7th grade level of understanding how capitalism works, right? You have a production company that makes, in this case, Pepsi Cola. It goes on a truck, gets delivered to a shop where people go in and pay for the Pepsi. And this is a very easy to understand capitalist method of being productive and successful, because it's very simple to understand the different parts that everyone plays in the process. So how is it in a country as modern as the United States that when it comes to the sequence of events that take place when you're filling a prescription looks more like this, where there are multiple back and forth wholesalers, drug companies, insurance companies, pharmacies, and then there's that little green guy at the bottom left of the corner of your screen, the uh, pharmacy benefit manager. And one of the questions I had when I first started this, and still have, is what the hell are they doing there? Because these are people who don't add to the process of the supply chain, and all they do is actually slow it down and make it more expensive. So let's look into that. Pharmacy benefit managers were, and I use the term outside companies, you'll see why in a few minutes, were designed actually to decide what drugs to cover, which ones to force patients to pay a larger share for, and their main reason for existence was to negotiate lower pharmaceutical prices. In March of 2018, which is now 5 years ago, over 5 years ago, close to 6 years ago, there were 3 companies, Express Scripts, CVS Caremark, and Optum, that controlled 72% of the US market of prescriptions. Since that time, in the last 6 years, it has become even worse. They now control over 80% of the prescription drug market. And what's the problem with these 3 companies? Well, the problem is that each of these 3 companies are no longer a company by themselves. So CVS Health and Aetna merged and became a very large PBM / insurance company. The same thing happened with Cigna. They bought Express Scripts to become a very large PBM / insurance company. And Optum was doing such a good job for United Healthcare that they asked the CEO of Optum to become the CEO of United Healthcare. And so these 3 companies have become probably the main problem that we have in drug prices. And if you take a look at this article from JAMA just a few months ago, it really tells you a lot of what's going on. Over the last decade, attitude towards PBMs have changed significantly. One reason for this change was the scope attained by the PBM enterprise. CVS Health, United Health, and Cigna have grown to constitute the 4th, 5th, and 13th largest companies by revenue in the entire United States. Okay, we're not talking about large companies that tend to bully people. We're talking about the 4th, 5th, and 13th largest companies in the entire country. And that is one of the problems of how we're going to deal with price of medication. And it's not enough that they're started with just the PBMs and the medication and drug prices. They have now gotten into the service business, the healthcare practitioner business, where United Health signed a Medicare Advantage deal with Walmart. CVS Health in the last year has spent about $11 billion, $8 billion to buy a home healthcare company. Okay, this is CVS Health, which is a PBM / insurance company. And they also paid 10.6 billion, almost 11 billion, just for a primary care practice, a national primary care practice. So that's close to 20 million, sorry, close to $20 billion that CVS Health has spent in the last year or two in acquiring practices. Okay, that is not drugs, that is not health insurance, that is starting to control the delivery of healthcare. And this is the vertical integration from hell, right? You have an insurance company that's also a PBM, that's also its own specialty pharmacy company, and now they're controlling provider services. So they're going to control the entire supply chain of healthcare from the time that a patient is seen until the time that the patient's medication is delivered. And this is problematic. It doesn't allow for a lot of variation, and it also portends poorly for physicians who basically are going to be told how to practice based on a health insurance company or PBM's desires. So, what strategies do the PBMs use to control drug prices? There are many different strategies that they have. I'm going to go over about 5 of them in today's talk. So the first one is known as copay clawbacks. So this is the way a transaction is supposed to occur, right? It's between your insurance company and the drug maker. The PBM was supposed to be negotiating the price. What happened was that the PBM, and a lot of the problems with PBMs is that they have arms like octopuses, right? They have their hands everywhere, and they decided that they weren't just going to control the price between the drug maker and the insurance company. They were also going to control the pharmacy and what they did. And sure enough, a simple bottle of metformin, which would cost a pharmacy $1.61, would sell it then to a patient for $4, and it would yield a profit for the pharmacy of $2.39. And that was the simplified version of the animation that I showed you earlier, where everything made sense from a capitalist perspective. In comes the PBM and puts themselves between the patient and the pharmacy. And what happens to that $1.61 bottle of metformin? Well, they decide and tell the insurance company that you have to tell the patient that it costs $11 now to get that bottle. We'll give the pharmacy $1.93, which is less than they would have made in the old system, and they'll take the difference, close to $9 from that 11, for themselves, for no good reason other than they can. And this was a bigger problem even than what it used to be. And I'll tell you what it used to be in just a second. I'm not showing you this picture to trigger anyone, and I'm not even focusing on the guy at the podium. The guy next to the guy at the podium, Alex Azar, was the secretary of HHS, Health and Human Services, and had a lot to do with almost blowing this whole thing up and peeling the curtain back on the PBMs. Came very close. We'll go over how close in just a bit. But what they did do is in October of 2018, they passed the Patient Right to Know Drug Prices Act. And what that allowed pharmacies to do was it allowed pharmacies to tell you as a patient, hey, if you don't use your insurance, it's actually going to cost you less to get this medicine. Until October of 2018, they had gag clauses in place from the PBMs that would not allow a pharmacist from being able to tell you that. It took an act of Congress signed into law by President Trump that allowed a pharmacist to actually tell you that you could actually purchase your drug for less without using your insurance. Spread pricing. It's basically just a way to skim off the top. And what it is if you think of a drugstore buying a bottle of pills for $6, they add $2 for their own profit and they sell it for $8. Well, what happens when a PBM comes in? They say, no, you don't buy it for $8. You're going to have to buy it through us for $16. And then that difference between what the pharmacy sells it to a patient and what the PBM is acquiring it for, right? The acquisition price is 8, but they have to sell it for 16. That difference doesn't go to the pharmacy, it goes to the PBM. And they did this, and they can change it all the time, and they do. And they've done it to a few, believe it or not, Medicaid programs, which is really horrific. But we'll take a couple of examples. Generic Gleevec, imatinib, came out in 2016, was extremely expensive, $9,500 to a patient, but it cost the pharmacy $9,000 to acquire it. So there was a $482 delta, which is reasonable at that kind of cost level. What happened was, as Gleevec became generic and more affordable to the pharmacy acquisition price went down to close to under $4,000, but the PBMs weren't telling the insurance companies or the patients that it was that low. They were telling them, hey, we have great news. The cost of getting Gleevec for your patients is no longer $9,500. It's only, quote unquote, $7,200. But they got it for $38.59, which left a delta of $33.42, not for the patient, not for the pharmacist, not for the pharmaceutical company, but for the PBMs. And they took that spread. Same thing for generic Abilify in New York. Again, the Medicaid program. They were allowed to continue to charge higher spreads in order to make more money as a PBM. And that led Ohio actually to go ahead and start their own pharmacy benefit manager because they were getting fleeced by the big three. They've also started to sue. Medicaid programs have started to sue the PBMs for their behavior. Rebates, and when I say rebates, I'm not referring to rebate cards that you might get from your physician's office. I'm talking about the rebates that pharmaceutical companies have to pay PBMs to get on formulary. Some people would call those kickbacks. There are a lot of euphemisms in healthcare. Rebates is one of those euphemisms. So what's supposed to happen is the PBM is supposed to negotiate with the drug makers and get a low price for the insurance plan. What ends up happening is they go to the drug makers and they say, hey, if you give us a high enough drug price where we can skim off the top of it, we will put your drug in a favorable place on the formulary. So they're basically negotiating placement on the formulary based on the amount of rebate that they're willing to give the PBM. So instead of the patient's costs going down, the PBM's profits go up. Why don't we know about this? Why don't we have people yelling from the rooftop, you know, we're sick and tired of this and we're mad as hell and we're not going to take it anymore? Well, the reason is a lot of this is just opaque. In a world where transparency is the buzzword, opacity is the buzzword for PBMs. They don't have to tell anyone how much they're getting in rebates, how much spread pricing they're collecting on, or how much they're clawing back at the copay level. They don't have to tell anyone because they're protected by a law. The 1987 Medicare Anti-Kickback Safe Harbor Law would make it clear that they would have to tell people what they're doing in order to show that they weren't getting a kickback. However, for some reason in 2003, the exemption to the anti-kickback safe harbor was given to pharmacy benefit managers. So they're exempt from a transparency law. I don't like to talk ill of the dead. For those of you who don't know who this person is, it's John Gotti, who was a big mob boss in New York for a long time. John Gotti, if he were alive, would be hitting his head against the wall in his cell thinking, why didn't I think of that? Because here you have a PBM, which is essentially organized crime. They're putting their hands in the pockets of our patients and taking out money from the process while contributing nothing to it, just like the mob does, and not having to tell anyone what they're doing because they're protected by a law. So it's basically organized crime that's protected by the laws of the land. It's a pretty good gig if you can get it. Remember, I told you that Alex Azar came pretty close to blowing this whole thing up, and he did. Came up with a genius plan where he decided what he's going to do is take the anti-kickback exemption away from the PBMs and instead give it to the patient. So a patient would be able to get a kickback or a discount at the pharmacy level, and it wouldn't be considered a kickback. So he would be taking away the exemption from the PBMs, and he would instead give the exemption to the patients. It was a genius plan. And unfortunately, it came at a time when President Trump was running for re-election, and his advisors told him that if he went ahead and did this, that Part D premiums of Medicare would go up, right when he was running for re-election. And at the press conference where they announced that they were no longer going to go through with this, Azar said that at the end of the day, while we support the concept of getting rid of rebates, we're not going to put seniors at risk of premiums going up. He contended that rebates days are numbered, which they haven't been, because we've totally changed the debate on rebates, but that really hasn't happened. And this is not shocking. The decision drew praise from pharmacy benefit managers who would have been most hurt by the proposal and who had lobbied members of the Domestic Policy Council and top health officials to drop it. And that's starting to get into the political realm that we'll get into in just a minute. Copay accumulator cards. This is another really unfair practice by the PBMs where, and I call it the deductible double dip. Now I am referring to those cards that you get from those pharmaceutical companies that tend to help you buy those first few months of your medicine, especially if they're biologics or other high cost medication. What happens is that medication goes toward what used to happen is that the cost would go towards the deductible of the patient. So by the time that rebate card ran out of money, because it was only a maximum of 3 or 4 months worth of covering the medication cost, that the patient's pharmaceutical deductible will have been met, and then it comes out of the patient's insurance. What the PBMs decided to do with their brother payers was to say, okay, we'll take that money from the pharmaceutical company, that card, but we're not going to credit your deductible. So basically, as the card ran out of its money, the patient's deductible was untouched. And so the patients were responsible for their full deductible amount. And this was it's a very mean thing to do. Another just strategy of the PBMs. And then finally, the one where physicians know all too well, and that is all these barriers to access, prior authorizations, step therapies, restrictive formularies, and failure to pass rebates on to patients. Access has been one of the main problems in healthcare. It's one of the main causes of burnout for physicians, right? How many of you have called the doctor's office because you can't get prior authorization for your medication? Well, until 10 years ago, there is no doctor's office that ever had to deal with a prior authorization. This is a new problem for physicians and their offices. And the only way that they've dealt with it is actually to hire full-time people, again, increasing the cost of healthcare. And unfortunately, the physicians can't pass on that cost because their reimbursements are not going up, they're actually going down. And so this is one of the reasons that your physicians are starting to burn out. And this is a list of formulary exclusion lists. When the PBMs first started in 2012, there were fewer than 50 medications that wouldn't get filled when you took a prescription to the pharmacy. Now, that number is up to over 450. So there are almost 500 medications which can't be filled at a pharmacy without your doctor's office doing something to try and get it filled. And that makes access extremely difficult. So what can we do? Well, a lot of people have already worked around this a little bit thanks to the law that we talked about earlier. They're using GoodRx. And GoodRx is a very good plan to use if you want to get good discounted costs of your medication. It does not go through your insurance. The reason a lot of physician practices don't like it is because they do offer provider visits, which may mean that your patients no longer will be using you because they can get their medications now through GoodRx by just calling directly and getting a provider on the phone that will renew their medications for them. But another reason you might not want to rush to GoodRx is because they were just earlier this year, they were found guilty of releasing consumers' health information to Facebook, Google, and the FTC was not pleased. And what they did was they actually made them pay $1.5 million in civil penalties. Where I'm from in New York City, they just call that the cost of doing business. And unfortunately, they are not to be trusted with your healthcare information. What about Mark Cuban? Mark Cuban came out with his pharmacy, and I think that this is great. The Cost Plus drug company that he put out is fantastic. It actually this is a flow chart from his own website where if you take a look at the supply chain and then you see what Mark Cuban tries to do, it starts to make you want to think about the animation that I showed you earlier on, right? We're taking this and turning it into that, and that's what Mark Cuban's trying to do, and he's doing a pretty good job. I can tell you, there's a topical medication in dermatology where patients have been paying upwards of $200 to $300 for a tube of cream, and they're able to sell it for $8.42 plus the $5 for shipping is $13. Delivered to your home. So there are disruptors in the area that are making it. I think Cuban has probably the best disruption so far, but so does Amazon. Amazon has a great pharmacy where it gives you a lot of transparency. It shows you how much the medication would be if they put it through your insurance. It shows you how much it'll be if they don't put it through your insurance, and then you have the choice. And then when you choose, it then delivers it through Amazon Prime the same way you get everything else that you order online. So there is disruption in the market. What else can we do? Well, a lot of physician associations, including the American Academy of Dermatology, we would spend a lot of time advocating for legislative fixes for this. And you'll see transparency in a lot of these laws. But every year, these bills would be presented in Congress, but they would never pass. And every year they would have to be renamed because every year it has to have a new bill introduced. And so what we saw happening was every year there would be more crossed out, more brought up, until more were crossed out than were ever being brought up. But I will tell you that in 2023, and this is now the bills that are in Congress, in the House and in the Senate, and they have a much better chance than ever to pass. But I will only believe it when I see it. And the reason for that is that political issue that I brought up early on, and I've alluded to throughout. And that is, if you go to opensecrets.org and you look up these companies, you will see that they are not just some of the highest donors, but take a look at the spread. Take a look at the blue versus red. These PBMs don't care who's in power. They could care less if it were Democrats or Republicans because they're in everybody's pocket. So they don't care who is in the White House. They don't care who's in the House, and they don't care who's in the Senate because they have been able to control all of them. And what in DC, where no one can even agree on what time it is without being partisan, the one thing you can do, which really is the kiss of death to anything, is to say that you need larger action, or you need comprehensive reform, because that basically is the death knell for anything like immigration, and certainly it would be for drug pricing if a lot of these people's campaigns are dependent on PBM money. And that's what happened last year. At the end of the year, there was an omnibus spending bill. At the very end of the year, Christmas always brings out the urgency in Congress because they want to go home for Christmas. So they passed this thing. But in order to pass it, they actually had to remove a PBM transparency bill that passed the House of Representatives. And this is the kind of ping pong that occurs every year. The House passed a bill and the Senate pulled it out of the omnibus because they know that this is the way the game is played. And so there was no transparency law that was passed last year. I am hopeful that there will be one this year. FTC has gotten involved and has launched an inquiry into the prescription drug middleman industry. So there is definitely more acceptance to trying to do something about this than ever before. It probably needs even more fuel in the fire, and this is one where LA County is gonna sue the pharmacy benefit companies for being involved in the opioid crisis. There are other studies that have come out of USC where generic drugs have been exposed to be having had the same thing done, where all of a sudden drugs that were pennies for a pill are now hundreds of dollars, and it's just craziness. And the AMA summarized that study with a quote that I have up here, just because it actually talks about most of what I talked about during this lecture, which is spread pricing, copay clawbacks, and formularies that take advantage of branded drugs over less expensive generics. And it is really starting to get a grassroots movement that basically culminated with this 60-minute episode, which if this were on every weekend, it would definitely change the minds of politicians, because their voters would be yelling at them. I want you to take a listen to this. I'm going to play the video for you. Leslie Stahl pretty much figures out everything that I just told you, and is just exasperated and infuriated by what she's going to hear. She's speaking to the CEO of Kaleo, a pharmaceutical company that raises the price of one of its medications in order to improve access. So take a listen to this, and I'll come back on afterwards and wrap things up. Oops. Let's try again. Lauren, is that able to be seen?
I can see it, I just can't hear it. Do you
Okay,
have the
so
actual link? Can you type it in to the browser?
there is no link. It is a recording that I made.
Gotcha.
So that is unfortunate, but okay. I can tell you basically what was in the video is she's finding out that and I'm going to go on camera now so we can finish up. She's finding out that a medication which is designed as a drug that is supposed to save people who overdose, naloxone, in order to improve the access for the naloxone, they had to raise the price. And she was a little confused. Why would you have to raise the price in order to make something more accessible? And then went through the explanation it's because of the middlemen, these pharmacy benefit manager middlemen, who are basically asking for higher prices in order to satisfy their profit lines. And if they got the high enough prices, they would then make the drug more available to the patients by allowing the pharmaceutical companies to put it on their formulary in a better position. And so these are the type of behaviors that we've had to deal with over the last few decades that have operated pretty much in secret because they've hidden behind this law, that the anti-kickback statute exemption. And it is unfortunate that that the PBMs have been not been held up to a transparency law. Physicians are held up to transparency laws. We do have to disclose all of the income that we make from, say, pharmaceutical companies. Pharmaceutical companies have a lot of transparency that they have to give because they're public companies, but the PBMs don't have to show anything for how they make their rebates and how they make a profit. Hopefully, with government intervention, this will change. The PBMs are starting to diversify, as we went into earlier, by now acquiring provider services that will allow them to control the supply chain in other ways. And so these are the type of strategies that we have to be aware of, that we all need to complain to our congresspeople about, because the only way that this is going to change is if there's a groundswell of grassroots, because as I pointed out, the politicians may have other interests that supersede the best interests of the patients in this country. And with that, I would be happy to turn over to you, Lauren, and any questions that people might have. Thank you.
Thank you, Dr. Kaufmann. One question I did have was, do you have, for our viewers around the clip, do you have the date of that particular 60 Minutes episode so that they could potentially find it later? Is there a date? Was that for this year?
No, it wasn't this year. It's got to be at least 5 years old. And this was, the PBMs, I think, responded to it initially, and then they realized that the best way to deal with this was to just let it die, and it didn't really gain any traction. What is needed in order to really bust them up is to have this all the time, to have an article in the Wall Street Journal, in the New York Times, on a daily or weekly basis that brings this up all the time, because people, have these days have very short attention spans, and even if they would put this on again, I doubt it would cause any lasting difference. But it's if you like, I can try and find the date, and I'll get back to you with it, so you'd be able to list it on the website.
Sure, because then I can, when we upload the video, then I can add that link to it with the description and the YouTube and the website links.
What I will do is also I'll be able to upload separately the video to you, and you could probably just put it on the website.
Sure, because I think, like you just touched on and mentioned, the more awareness that we bring to this issue, I feel like people would get a lot more emotional and quite frankly angry. But maybe if we made a TikTok video, you might get some leverage on it. I'm not sure, because that seems to be pretty helpful on a lot of different issues that aren't as serious. I will say I love the John Gotti analogy. So New York, and but quite frankly, it's so true, unfortunately, around a lot of different things. And you also touched on the prior authorization process, and that getting more and more difficult, and the burden being put on physicians a lot more. And I do know one of your colleagues, Dr. Michael Gold, who is on one of our medical advisory members, has, I think he told me, 5 full-time staff just to do prior auths, and he needs more actually. And that was kind of a moment for me, like I was like, 5 just in your private practice. And he is a dermatologist in Nashville for our audience members, and in solo private practice, and still has the need for 5 full-time staff members. Quite mind-blowing. Now, you touched on, Dr. Kaufmann, what do you recommend to patients and advocates do about helping some of these issues? You listed quite a few, but is there anything else that you feel that could be done? Because many times, as we all know, things don't always happen in Congress except a lot of arguing, right? So do you feel that there's any other pathway to go down besides the one in DC that requires a lot of arguing, right?
I wouldn't. I mean, this is the first year that I think it actually is worth an extra effort to try and reach out to your Congress people, to your senators. There are some senators now that are breaking out a lot of charts that are very similar to some of the stuff that I presented this evening. And so I think we are closer than ever. And I think, honestly, the PBM's days are numbered, at least in operating in the way that they've been operating for the last decade or two. So I think there is hope. I don't know what PBM's 2.0 is going to bring, but I think there is a strong enough groundswell for transparency that I think reaching out to your Congress people is important in this matter. I think it's the only way is for them to get more phone calls, emails, letters from their constituents than the dollars that they're getting from the PBMs. That's the only thing that they'll respond to is numbers.
Oh yeah, I always tell people, what I'm on the Hill a bit advocating for patients and healthcare providers, right? And the one thing I always tell other folks is that numbers get their attention. Start throwing out numbers, and they'll turn heads for sure. It's just kind of ironic. I always felt this around the PBM issue with, really Congress let these huge mergers happen, right? And so to me, it's kind of ironic that they're like, oh, well, we didn't know that was going to happen. So now we need to do something about it. But you knew it was going to happen. And that's what's, I guess, very, very frustrating. The congressmen and women, the FTC, like everybody knew, and they let it happen. And we live in a country where we don't, it's frowned upon with monopolies. Well, you did it. And now here's the repercussions, right? So I've always had that outlook in the last, 5-8 years on this specific topic, because the PBMs are also very, very intelligent people, and they like to play the game, as you mentioned earlier. So they're gonna continue to skate by, is my fear. I hope not, but they're gonna weasel their way around these new policies in place, and that where does that go? That backfires onto the patient, right? And continuum of building the cost, out-of-pocket costs for them, et cetera. So anyway, I didn't want to go down that rabbit hole, but
it's funny because I kind of look at them as the devil that I know, because I now know them, and I'm a little anxious about what phase 2 will be for PBMs once this door is shut, and it will be shut. If it's not this year, it'll be next year, but it'll be shut, and I'm more afraid potentially of the control that they're going to try and show over their providers, and telling them what can be prescribed and what can't be prescribed, or else, you're fired and you have to go try and find a job somewhere else. It's becoming less and less likely that most people's physicians will be in private offices anymore. It's going to probably be within a system, whether it be a hospital system or a multi-specialty clinic. That's just reality. There are fewer and fewer physicians that are going into independent practice because the reimbursements for physicians is and their practices is going down.
And that's one of the things I also share with patients as they're reviewing plans and what area they're in the country, as well as the healthcare providers. This all too well is that UHC is one of the worst has the worst reimbursement rate in the Department of Payers, and that is why I educate the patients on when they pick their plans and make sure you review that information, because not everybody's going to know that, right? They're just thinking this is, it's an insurance plan, I've got to have it. But how the reimbursement also affects their care, and it's the same issue. The physicians that are just getting swallowed up by these hospital systems, unfortunately, aren't able to navigate the private practice anymore because it's not affordable because of reimbursement. But the same thing is happening in the pharmacy world, where, as you know too well, the smaller mom and pop pharmacies are being absorbed by the Walgreens, CVS's, the payer pharmacies, right? And they can't afford to stay open. And unfortunately, most of the U.S. lives in rural USA, so they're driving, hours to get to the doctor, to get treatment, to get a prescription filled, etc., because there's just nowhere to go because of all these. It's such an unfortunate mishaps that again affects a lot of patients and a lot of healthcare providers across the U.S. So I'm really appreciative that you are so passionate about this specific topic, and you are also a very significant advocate on the Hill for both the healthcare providers and the patients as well. So I do appreciate you doing all that you do in this specific area. So sorry, I want to see if we have any questions, audience member. Anybody? I feel like some of these folks would be very interested in this topic. One thing that is pretty frustrating as we are coming up to the end of open enrollment is, I figured this out really quickly several years ago, is that, the insurance companies like to play this game as, we're going to not show you all the pieces, but you have to pick a plan, right? Whether it's the benefits booklet or a summary or whatever it is of the plan for the following year that you're picking. So it's this game of, I have to pick a plan, but I might not get coverage for it's a guessing game for my drug or whatever service is provided. And I feel like that specific issue is not often discussed or brought up, or maybe just folks aren't aware of it as much. But it's a real issue because that is so wrong and so illegal as well. If you're, if you get the whole 110-page benefits booklet, that should be in there, right? Information, but unfortunately, they changed the game. They changed the cards as they're playing the game. It's not a one and done. So I don't know if you were aware of that issue or if you had any thoughts on that specific scenario, just because, in another 17 days, we'll be at the end of open enrollment, kind of. So
yeah, I was not familiar with it, but it's not surprising because, again, the merging of PBM strategies with insurance company strategies is never going to yield something beneficial for patients.
Never has. So,
Yeah.
and thank you for all this very enlightening information, but also scary information as well. Are there any other questions from our audience members? Okay, no John Gotti questions? I thought that was best. Okay, well, thank you, Dr. Kaufmann, for being with us this afternoon and taking time to educate our community. And thank you to our audience members for tuning into this evening's presentation. And please don't forget to register for our next educational webinar on January 25th with Executive Director and President of Prevent Legionnaire's Disease, Tanya Winders. Also, in lieu of Giving Tuesday, if you have enjoyed today's presentation, please consider making a tax-deductible donation to AAIDA on our website at www.godoaida.org. And your contribution will help us to be able to conduct educational initiatives such as today's webinar and be a resource for our patients and medical community that we serve. And do please take a few moments to fill out our quick 5-question survey after the conclusion of today's presentation to help us better serve our patient community. Thank you so much, Dr. Kaufmann, and have a healthy day.
Thank you, Lauren. You too. Bye-bye.
Thank you. Take care.